Nick Majerison here. Welcome to Top Med Talk. Thanks for downloading the podcast. If you're enjoying what you hear, do make sure you've subscribed. This week we're presenting to you our Xtreme Everest mini-series. Today's presentation is called Oxygen and the Brain. It's presented by Chris Imray. Have a listen.
Top Med Talk.
Thank you very much indeed. It's a great pleasure, and thank you for the organisers for inviting me. What a wonderful setting. I've never been here before, and I got off the plane at 11:30 last night and thought, wow, it's warm here. Some disclosures, as is conventional. Another important disclosure, Joe Brabble's a good friend of mine who I now know well, but at the time was a rather intimidating person whose altitude group I was trying to get involved with. And his comment was that I've never met an intelligent surgeon in my life. And I'm sure I'm not going to disappoint you today. The one person who is missing is an intelligent surgeon, and that's Mark Wilson, who has done a lot of this work that I'm about to describe with you. So he's a neurosurgeon back in the UK, but unfortunately can't be with us today. In terms of my background, I'm a plumber, and I have a particular interest in extreme environments, in particular altitude and cold. And I'm trying to summarise in the next 20 minutes or so my PhD, which is 15 years of work, looking at cerebral hemodynamics in man, clinical and applied observations. So I'm going to talk a little bit about history, then talk about cerebral oxygen delivery in particular, neurological effects of ascent to altitude, cerebral oxygen delivery in carotid surgery, something looking at high altitude pathologies, and then end up with some potential translational implications, which I hope will generate interest from those of you who aren't planning to go to altitude shortly. So, just starting back in 1862, we're now in the Midlands, which is where I come from in the UK. The great fashion, the big advance then, the excitement was going hot air ballooning. And a couple of people, a guy called James Glaisher and Henry Coxwell, took off from the gasworks in a balloon. And they flew up to a total of 28,000 feet, but began to run into trouble. At 29,000 feet, one of them recorded, I laid my arm upon the table, possessed it of full vigour, but being desirous of using it, I found it powerless. So possibly the first extreme hypoxia TIA. So the brain is an important organ, as I'm sure you're aware, but it's hugely energetically challenging. Although it only accounts for 2% of the body weight, something like 15% cardiac output and 20 to 25% of body oxygen consumption and glucose consumption. Flow is high. Glucose is the obligatory energy substrate with negligible stores. And you can see here on an early PET scan the relative preponderance of oxygen delivery to the brain compared to the heart and the liver. So autoregulation is something that we all learn about, but it's an important thing when we're going to start changing both the PiO2 and the PaCO2. Blood pressure is a key determinant of cerebral blood flow, and it's constant over a long period of time. But you do run into problems either at extreme high blood pressure or extreme low blood pressure. Arterial carbon dioxide and arterial oxygen are the other two major determinants. And you can see here at low oxygen levels, so this is what's happening at extreme altitude, you see an increase in cerebral blood flow. And at high CO2 levels, you again see an increase in cerebral blood flow. The problem is that as you hyperventilate at altitude, you actually drop your CO2. So we've got two completely different approaches here, where we've got a drop in CO2 tending to reduce cerebral perfusion, and a drop in O2 tending to increase it. There are other factors that will determine local flow, and that's local metabolic activity and neural autoregulation. So what happens at altitude? We've talked about the general factors. In the earlier talks, we've talked about hyperventilation, heart rate, and hematocrit, all of which tend to increase oxygen delivery. The brain, however, has some specific ways of coping. It has this very high metabolic requirements, and so there needs to be some way of increasing cerebral blood flow to maintain cerebral oxygen delivery. And you can see here, if you follow the black line here, there's an immediate drop in cerebral blood flow, but this tends to go up over a period of hours and the first couple of days before returning towards normal. The other challenge that you've got with the brain is that it sits within a fixed cranial vault, with a fixed volume. And this means that any swelling that occurs there can adversely affect flow. So although the initial changes may be advantageous, if you then end up with high pressure within the cranial vault or raised intracranial pressure, then you can run into serious problems. So if we step back a little bit and just talk in general about mechanisms that are involved in cerebrovascular dysfunction, there are a whole series. The hypoxia that we've been talking about, hyperperfusion, and that might be hemorrhage, or embolization. But the common feature in all of these different clinical situations is an inadequate delivery of oxygen to the tissues. ATP is the universal energy currency. That is the source of energy that drives the whole process. And it requires oxygen to take us through this in order to generate from ATP, which then maintains cell membrane, allows the cells to function. And if we look at the effect of anoxia on ATP, what we've got here is ATP turnover on the vertical axis here, and then time for anoxia. And what should be happening is that we should have an equal supply of ATP, and that should balance with the demand. But with a gradual reduction in oxygen, you get this mismatch, so that you gradually see a diminution in the amount of ATP that's available. And if you follow this through to the end process, you can see how one eventually ends up with cell death. And this is clearly going to be very challenging. Going back to altitude and the neurological effect sent to altitude, you can divide the sort of problems that you run into either the acute or the more chronic. So the acute would be equivalent to explosive decompression in an aircraft, where you've suddenly exposed to a very high altitude or very low FiO2. And then a more gradual decompression, where what happens is this was more equivalent to us trekking up to altitude. And on acute exposure, there's a profound loss of cerebral function in particular that occurs very quickly. And at somewhere around about 15,000 feet, one will be unconscious within 5 or 10 minutes. And one goes higher still, it occurs more quickly. This is a study that goes back to 1932. This is Fitzgerald, where what he was getting someone to do was to write with different levels of inspired oxygen. The first one in the top corner there being equivalent to breathing room air at sea level. And the last one in the bottom corner there is the FiO2 of somewhere around 7% or 28,000 feet. So before they go unconscious, this is how their writing begins to deteriorate. So you can see this is all going off really very quickly. So we've got two different processes going on here. We've got a situation where the cell metabolism is in balance and working well, where the oxygen consumption is delivering enough ATP to do the work to allow the cells to function normally. And then we've got the situation where we're out of balance, where we've got lower levels of oxygen and the ATP stores are beginning to get depleted with the resultant effects. The thing that's interesting in this particular situation is that there is spillover of the ADP into some of the breakdown products, particularly adenosine and hyperxanthine, and this can be actually picked up in the peripheral circulation. So what we've done is we've taken a model, a carotid endarterectomy model in humans to try to investigate this a little bit further. So carotid endarterectomy, I'm sure many of you are familiar with the procedure. It's an operation performed to reduce the risk of future stroke, and it can be performed either under local or general anaesthesia. The advantage of doing it under local anaesthesia is you can make real-time assessments as you go through the procedure of how the brain's getting on. You then get an indirect assessment of cerebral oxygen delivery. So what we've done is develop a technique that will allow us to actually measure these purine breakdown products in the peripheral circulation using what we call a smart chip. If we look at the sort of results we get, this is what we're seeing. So we've got purine levels on the vertical axis here, and during the procedure with time on the x-axis. And this is the clamp phase in pink. And you can see relatively low levels, somewhere around 1 micromolar per litre before clamping, and then a dramatic rise within minutes with the clamp going on. And then as you release the clamp, this drops back down to normal fairly quickly. So what happens when we're doing a carotid endarterectomy? There's a graded degradation in the cerebral function of the patient. So they'll often start off chatting. They're quite good at initiating new lines of conversation. Their conversation will go here, there, or everywhere. And then they start to get a bit of a sense of humour failure. Now, it's not surprising with your neck wide open that possibly a sense of humour failure might result, but this is actually the beginning of what's happening when you're getting a lack of oxygen. They then get a very rigid conversation and they're quite restricted in where they can go and their thought processes. You start to get monosyllabic answers, you get loss of motor power, and then they're unconscious. And this is challenging, clearly, if you're the surgeon or the anaesthetist. And it's possible at this point to put a shunt in, so that you're able to shunt the blood from the common carotid up into the internal, bypassing the operative field. So what happens to the purines? You can see here, we're starting off with a higher level of the purines. It would suggest possibly that brain was slightly more challenged. And the result of cross-clamping is they became unconscious, but on inserting the shunt, it drops very quickly back towards normal. The patient wakes up and you can continue the procedure. So what's that got to do with altitude? So there was an article written by George Rodway where he talked about the loss of executive function at extreme altitude. And I would suggest, and certainly those of us who have been to extreme altitude, there is a not dissimilar stage reduction in your cerebration, where certainly sense of humour begins to go, and perhaps some of your more higher thought processes become limited and you're more restricted in what you do. I suspect you might become a more dangerous climber. If we look at a study that we published in the BMJ looking at the mortality on Everest between 1921 and 2006, we looked at a total of 14,000 mountaineers over that time and investigated the cause of death. There were a total of 212 deaths in that period of time, of which 94 had occurred over 8,000 metres. What we found was a very distinct breakdown between those people that were dying high on the mountain. The Westerners were dying high on the mountain, above 8,000 metres, whereas the Sherpas were dying low on the mountain. And yet we've been hearing earlier today about how the Sherpas are well adapted. And what was happening is the Sherpas, unfortunately, were dying from traumatic causes. They're going through the icefall far more frequently and are at greater risk of problems there. Whereas the Westerners are running into serious trouble as they begin to stretch their metabolic envelope, if you like. If you look at the arrival time on the summit of survivors, you can see here that the median arrival time of the people who come down alive is somewhere around about 9 or 10 in the morning. Whereas if you look at the median summit arrival time of the non-survivors, these are people who clearly don't make it down in one piece, it's somewhere nearer 3 or 4 in the afternoon. So just the time at which you arrive on the summit of Everest is a good predictor of what's likely to happen to you over the next few hours. So just a little bit more about high-altitude pathologies. There are 3 distinct ones that we commonly recognise. One is high-altitude headache, and this will tend to come on fairly quickly, often on the day you're ascending. Acute mountain sickness often will take a night or so to develop, where you start to get headache, nausea, loss of appetite, dizziness, poor sleep. And then there's a high-altitude cerebral edema, where the challenge here is ataxia, altered level of consciousness, coma, and eventually death. And this will often take place over a period of 4 or 5 days, and it's at a much higher altitude. And this is due to swelling of the brain within the confined cranial vault. If we look at some of the neuropsychological effects of sustained hyperbaric hypoxia, it seems to affect most aspects of the way in which your brain functions. So there's lots of data out there suggesting there are problems with arithmetic, memory deterioration, sleep disturbance, motor skills is an issue. Decision-making and risk-taking, I think, may well predispose you to, in that dangerous environment, to then running into further problems. So there are a whole series of things that are potentially challenging. Just going to talk about 2 studies we did on the Everest 2007 trip. First one is the Cerebral Perfusion study. You've seen the ascent profile a number of times, starting in London, going through Kathmandu, up to the South Col. And in this particular study, what we were trying to do, amongst other things, was to look at cerebral blood flow. Transcranial Doppler is the standard non-invasive way of measuring cerebral blood flow, but it's an inferred measurement. You measure the velocity and you assume there's no change in the diameter of the artery, and therefore that equals flow. And people have used that as a surrogate for the last 20 or so years. It's a very convenient assumption, but in fact it turned out to be an unreasonable assumption. So we took some sonocyte and a little bit of video footage, if we can get it to work.
Chris Imray, a vascular surgeon, is examining the most dangerous effect of high altitude, a lack of oxygen going to the brain.
This is absolutely phenomenal. I've never seen such a large artery. This is amazing.
The scan reveals an astonishing change in cycle.
We're now at 8,000 metres. You can see here this massive artery. This is roughly twice the diameter that one would expect. And this, I guess, must be somewhere this sort of size because we're trying to get a lot more oxygen there because there's so little oxygen around. This is fantastic. This is really exciting stuff.
As long as it gets me to the summit of Everest, I'm excited.
I think you can see what I'm talking about, disinhibition, changes the way people are thinking. This is like me being on drugs. I'm sort of super excited. I mean, yes, it was exciting, but I wouldn't want to trust that individual to make some serious decisions about whether to go up or down. We came down and we ended up doing an MR study to confirm the finding, but essentially what we found was that there was a significant dilatation of the middle cerebral artery at extreme altitude, and interestingly that reversed within 2 or 3 minutes of giving individuals supplementary oxygen, so it drops back down to normal. Why is that important? Well, we go back to Poissel, and he came up with his law which showed that if you double the radius of the vessel, you'll get a 16-fold increase in flow. Now, you don't need a 16-fold increase in flow, but you've seen that very sludgy blood that's going around. You certainly need an increase in flow to maintain cerebral oxygen delivery. Moving on now to the neuropsychometric test that was done. This was an interesting study done on the trekkers going up to base camp, where they did a whole series of different neuropsychometric tests, and I'm not going to go through them all there, but you can see we covered most bases there. What did we find? We found that there was significant problems with attention, learning, verbal abilities, and executive function all declined. And this is only going to base camp. This isn't going any higher. There's quite a big heterogeneity, so some of the individuals were much more affected than others. We found that the decline persisted on descent initially before getting back to normal. There's quite a wide inter-individual variability, and older people seem to be more susceptible. So again, an important thing as we look at our ageing population and how they might be challenged. So, just bringing it all together, what's the relevance of all this? What can we learn from these trips up high mountains? My own view is that I think we need to start to think rather differently about patients undergoing major surgery. I think we should be looking at cerebral protection strategies, and we should be much more overt about this. We need to identify those procedures that we think are higher risk than others. And in my own particular field, it'll be operations on the arch, the aorta, the TVARs, some of the carotid surgery, but the cardiac surgeons also need to think about it. You need to think what the mechanism is, because if you don't understand the mechanisms that's causing your cerebral dysfunction, it's very difficult to address the problems. And then, having decided what the mechanisms are, then I think you need to work out what your specific cerebral protection strategies are. And they may be relatively simple, like increasing the blood pressure or the FiO2, shunting. But you might think about cooling the patient, and the question then is, how cool should we make the patients, and is there a difference in the effect? One of my own pet things at the moment is deep anesthesia. When we did the Purine study, we saw absolutely no changes under general anaesthetic during the carotid endarterectomies. It's absolutely flat. I don't think we need to shunt carotids at all under GA, because I think the anaesthetists have already done a pharmacological cerebral protection strategy, but that's for discussion. I'm particularly keen on antiplatelet regimes, and I think you need to use them synergistically and look at the effect. And I think we need to be much more intelligent about our cerebral monitoring. They're all non-invasive and they're all surrogates for the real thing, but I think they're helpful. So I think you need to have a combination of approaches that are individualised to your patient in order to get the best outcomes. To summarise, we've looked at cerebral blood flow and we're understanding the importance of cerebral oxygen delivery balance. We've looked about rate of exposure and absolute altitude and duration of exposure. We've had some insights from carotid surgery. We've talked about some high altitude cerebral pathologies. We've looked at cognitive function and some possible translational implications. This is a huge team effort. I'm just a small cog in it, and I've had a brilliant time travelling all over the world, and it's changed my clinical practice significantly for the better, and it's been a pleasure to work with the Xtreme team. Thank you very much.
TopMed Talk.
Don't forget you can meet the TopMed Talk team, edpom.org/meetings. Our next big event takes place between the 28th and the 30th of September. EdPom USA Chicago Masters Course, a perioperative care practicum.